Hello guys, welcome back, and now we are going to start the crash course of complete denture. So based on the shape of palatal vault, if the shape of the palate is U shape, then this is the most favorable shape for the retention of the denture. So the most favorable shape is the U shape palatal vault. What if the palate is a flat palate? Say suppose these are the ridge of one side, then the palate is flat and this is the other side ridge. Now in case of a flat palate, there is resistance for the downward pull, so there won't be a downward pull, the denture won't fall, so there will be resistance to the downward pull, but the denture will be dislodged by the lateral or the rotational forces. So what if there is a lateral force coming? Then there will be fall of the denture. Therefore, balanced occlusion is mandatory and it must be given for a flat palate. If the palate is a V-shaped palate, say suppose if the palate is high and narrow palate, then that is most unfavorable palate for the retention of a maxillary denture. So most unfavorable for the retention of the denture. So what is the most favorable shape of the palate? That is V shape. The most favorable shape is a U shape palatal vault. What the least favorable, if they ask you, or most unfavorable or least favorable, one and the same thing. So that is again going to be a V shaped palate. If you tightly pressed against the side of the palate, it will loosen faster, so there will be fall of denture in case if you tightly press against the sides of V-shaped palatal vault. The most unfavorable V shape, most favorable U shape. Then what about if bony undercuts are present? If undercuts in the bone are present in the maxilla anterior ridge and present lateral to the maxillary tuberosity, then it should be relieved in the denture. But if the bony undercuts present in the maxilla are severe, then in that case we have to surgically remove it. If the bony undercuts are present in the mandible, they are surgically corrected. That means it should be surgically removed. And the reason behind is because of the mylohyoid ridge. So if there are bony undercut present in the anterior ridge and lateral to maxillary tuberosity, then it is relieved in the denture. If severe, then only surgically removed. As you can see, this is a maxillary tori which is generally present in the middle of the hard palate. And in the mandible, you can see this is the lingual tori that is present in between the premolars. So the lingual side of the premolars is the presence of the mandibular tori. Then if there are firm and bony swelling, then if it is present in the maxilla, then we keep it for the primary support. If the bony undercut or if there is firm and bony swelling present in the mandible, then we surgically remove it. If it is present in the maxilla, if the swelling is firm and bony, then we keep it for the primary support. Generally in the maxilla, we see this swelling of small p to huge size. In the mandible, you see this swelling to small p to small hazelnut size. So this is if the bony swelling is present in the maxilla. You can see this thin cortical bone. This is this thin cortical bone. So that's a thin cortical bone, and which is surrounded by a cancellous bone which is present in between. So in case if there is a bony swelling present in the mandible, it is surgically corrected. If it is present in the maxilla, then we see. If it is used as a support system, then we use it as primary support. But in the mandible, it is always removed. So in the mandible, it is surgically removed. That is before giving the denture, that is pre-prosthetically we remove any swelling in the mandible. So swelling can be from small p to half hazelnut. In the maxilla, if it is present as firm and bony, that means if it is tight swelling, then we use it as the primary support for the denture. When we remove in the maxilla is three scenario. Either if the swelling is extending till the posterior palatal seal area, then we remove it, or if it interferes with the speech, in case if it is present in the rug and it is interfere in speaking of the problem patient, then we remove it. Or if the swelling causes poor denture stability, then we remove the swelling in the maxilla. In the mandible, we always remove it. So remember, if the swelling is present in the maxilla, then we see if it is used as primary support, but in the mandible it is always removed pre-prosthetically before giving the denture. So if the swelling is present in the large tuberosity, if a swelling is represented as a large tuberous swelling in the maxillary tuberosity, if the swelling is movable, remember I told you, if the swelling is firm and bony, then we keep. If the swelling is movable, it will move the denture. Therefore, if any swelling is movable, then we remove it. And if it is firm and bony, then we keep it for the stability of the denture. So if the swelling is movable, it won't let the denture sit, therefore it is removed. But if it is firm and bony, then we use it as the stability of the denture. So when we talk about the areas in the maxilla, as you can see, these are the areas in the maxilla. So we have tuberosity, then we have crest of the ridge as J, then we have frenums. E is going to be the labial frenum, and you can see here we have the buccal frenum over here. So this is the buccal frenum. Then we have the incisive papilla, mid-palatine raphe. These are the rugae, and B is going to be the crest of the ridge. I'm sorry, B is the vestibule. So that's the vestibular area. So when we see the stress bearing area are going to bear the stresses, whatever stresses are coming on the maxilla, or basically on the maxillary arch. In case of a complete denture, these areas are going to bear the stresses. So stress bearing areas, primary stress bearing area is basically which is giving the support, or which is going to absorb all the stresses that are coming. That's why primary. So there will be very least amount of resorption, or we can say kind of a no resorption in these particular areas. These particular areas are the slopes of the maxilla. So whatever the slopes are there. So remember, primary are the slopes, because slopes, they are inclined. There is no direct pressure that is coming. So remember, slopes are always the primary. So wherever you see the slopes, for example, the horizontal slopes of the hard palate, and the posterior lateral slopes of the residual ridge. So basically the horizontal slopes of the hard palate, so these are the horizontal slopes, and also the posterior lateral slopes, so these slopes that are present on the residual ridge. In the mandible, we have buccal shelf area, also that is a stress bearing area in this particular, right? In the mandible also. So basically the posterior lateral slopes are going to bear all the stresses. So remember, the slopes are the primary stress bearing area. These have got least resorption, and secondary stress bearing area are the crest of the ridge. So remember one thing, that the crest of the ridge is a stress bearing area for maxilla, and crest of the ridge we cannot put pressure on the mandible, so it's a relief area for the mandible. So crest of the residual ridge is a stress bearing area for maxilla. It is going to bear stress. In the maxilla, we can put pressure directly on the crest of the ridge. So see, say suppose that's a ridge. So crest of the ridge is going to be this particular part, the crest, that means the top, the uphill part, right? So the top part. I can say the crest of the residual ridge is a stress bearing area for maxilla, but it's a relief area for mandible. Always remember this. Then we have a rugae area. Also, rugae are the secondary stress bearing areas for maxilla, and the maxillary tuberosity is also a secondary stress bearing area. Tuberosity is again a secondary stress bearing area for the maxilla. Then what are the supporting areas that are going to support? So we have a hard palate, rugae. Sometimes they directly ask you the support areas. So posterior lateral slopes are also going to give supports and the maxillary tuberosity. So these are the support areas. Then what are the relief areas? The areas where we cannot put pressure. So the relief areas we are going to relieve in the denture. In maxilla, it is incisive papilla. Since the incisive papilla is going to contain the nasopalatine nerves and the vessels, so this is the incisive papilla area. Then we have cuspid eminence. So cuspid eminence, or cuspid means canine and eminence means the prominence part. So the prominence which is present in the canine area is the cuspid eminence, that also we relieve. Then we have the mid-palatine raphe. So both of the palatine shelves are going to meet there. That is why we relieve the mid-palatine raphe area. We cannot put pressure on the mid-palatine raphe. So this is the mid-palatine raphe. This particular part is the relief area. Now, number of frenum that are present in the maxilla. We have total 3 frenum that are present in the maxilla. So 1 in the labial frenum. Labial. And on either side we have 2 buccal frenum total. So one side, 1 on each side. So that makes it 2 buccal frenum. In the mandible we have additional frenum. So therefore 4 frenums are present in the mandible. 1 in the labial frenum. 1 is the lingual frenum. So towards the tongue side also we have 1 more frenum. And 2 are buccal on each side. So coming to the House classification for the soft palate, the class 1 soft palate classification is when we have more than 5 millimeters of space present. So the junction between hard and soft palate and up till the posterior slope, we have got a soft palate off. That means after this is going to be the movable part. So we cannot use the movable part. So we have to use this basically this anterior vibrating line up till the posterior vibrating line, right? We can use up till the posterior vibrating line. After that, it is just the movable part of the soft palate and we cannot use it. So based on that, the soft palate that is used as a retention, that is used for our purposes, 5 millimeter for class 1. Since we have got such an amount, so that is why it is ideal for the retention. So there is more tissue coverage and also we have got the widest PPS, posterior palatal seal area, for a class 1 soft palate. So they can ask you which of the which class is ideal for the retention, which class has got the widest soft palate, or which has got the more tissue coverage. Second one, we have the palate, the area present between 1 to 5 millimeter. So first one is more than 5 millimeter, second one is between 1 to 5 millimeter. And you can see the angulation of the soft palate is somewhere around 45 degrees to the hard palate. So soft palate is going to be, see, this is a hard palate, then soft palate is going to be 45 degrees for class 2. For class 3, the area is less than 1 millimeters. So as you can see, the area is very small. So that is why it is poor for retention. And as you can see, this is the hard palate and the soft palate is situated 70 degrees to the hard palate. So here we have, that's 90, right? So here we have 70 degrees to the hard palate, as you can see. 70 degrees to the hard palate. Since there is very less amount of area present, and this particular kind of soft palate is seen in the V-shaped palatal vault. And if you remember, the V-shaped palatal vault has got the least retention. Therefore, the class 3 soft palate is also poor for the retention of the maxillary denture. Since we have got very small amount of area that can be used for the retention, also we have the angulation such a way that the area becomes very small, that is 70 degrees. So they can also ask you angle or degree for the class 2 palate, for the class 3 palate. Remember that almost 70 degrees for class 3, 45 degrees for class 2. The amount of posterior tissue will give us the PPS area. So more the PPS area, more is going to be the retention. Remember the class 1, we have more than 5 millimeters of the PPS area. Therefore, it is best for the retention of the maxillary denture. When we talk about the vibrating line, as you can see, the line which is present anteriorly is the anterior vibrating line, and it is a cupid bow shape. So it is narrow in the center, as you can see, and that is because of the projection of the posterior nasal spine. So that is why it has got a shape of cupid bow. Also, we can measure the anterior vibrating line using Valsalva maneuver. That is, we ask the patient to close the nostrils or to close the nose and then blow it. So therefore, we observe the immovable to slightly movable part of the soft palate. So basically, just where the hard palate stops, from till the slightly movable part of the soft palate is our anterior vibrating line. So from immovable to slightly movable is the anterior vibrating line, and the line is shaped in a cupid bow, like an arrow, right? Like this cupid bow. So also it is recorded when we ask the patient to say ah in short vigorous manner. That means very short and loud manner. So patient is going to say ah like this, very loud but short ah in a short vigorous manner. Posterior vibrating line is this one which is posteriorly present. So basically it is from slightly movable to completely movable. While on the other hand, the anterior was from non-movable to slightly movable. And the posterior vibrating line is in the, see, as you go down the soft palate, the soft palate is going to be more movable as you go posteriorly, right? So the one which is from not movable to slightly movable is the anterior vibrating line, and from slightly movable to completely movable is going to be the posterior vibrating line. So after posterior vibrating line, it is going to completely move the palate. So even if you give the denture will fall. That is why overextended dentures are generally fall down, right? So posterior vibrating line, we record it. We ask the patient to say ah in unexaggerated manner. So also this posterior vibrating line is present at the junction of aponeurosis of tensor valli palatini. So here is going to be the presence of tensor valli palatini muscle and the muscular portion of the soft palate. So basically here is what we see, the posterior vibrating line, which is present at the junction of the aponeurosis of the tensor valli palatini and the muscular portion of the soft palate. Then posterior vibrating line marks the distal extension of the denture base, because after the posterior vibrating line, all the soft palate is going to be completely movable. So if you give denture, the denture will fall down. So posterior vibrating line, they ask you which extends or which determines the most distal extension part of the denture base. So where denture base stops is at the posterior vibrating line. The most distally the denture base is going to be present at the posterior vibrating line. So coming to the PPS, also known as postdam. So posterior palatal seal area or the postdam, it gives retention. Posterior, why do we record this posterior palatal seal area? Because posteriorly it is going to provide a seal. Once it provides a seal, it will work as anti-gravity, because we also have gravity acting on the maxillary denture. So we want the maxillary denture to stick in the mouth. For that, we create a vacuum inside. So posteriorly, we are going to seal with the posterior palatal seal area. So basically, say suppose this is a palate, okay, and that is the posterior part. Now we are going to make this denture more tightly fit, compress the tissues posteriorly so that it creates a seal posteriorly, so that no food goes inside. If the patient is chewing, it is not going between the denture and the mucosa. Also, it is going to make the patient resist the gag reflex. So kind of vomiting or nausea, that is the gag reflex. So it decreases the gag reflex, it decreases the food accumulation since it provides a seal posteriorly, so there is no food going posteriorly. Also, it decreases the patient discomfort. It compensates for the volumetric shrinkage during the polymerization of the methyl methacrylate. Also, it creates a vacuum. So the most frequently question asked is, while recording the posterior palatal seal area, the head should be tilted downward by 30 degrees. Remember one thing, that say suppose when the patient is, or when a person chews or eat food, you are sitting on a dining table. So when you are sitting, when you are eating food, your face is not parallel to the floor. You slightly bend your head downward and then you eat. So we want to record this PPS so that when the person is eating, the food is not going posteriorly inside, right? So for that purpose, we make the head of the patient tilt to 30 degrees downward so that this mimics the position of the patient when the patient is eating. So basically, we slightly move the head down when we are eating, right? So that is why we record the PPS when the patient's head is tilted by 30 degrees. So that's the reason we tilt the head to 30 degrees downward when we are recording the posterior palatal seal area. And again, this is the most frequently asked question. Improper PPS. What if you have not recorded PPS properly? Either the extension of the denture is over and under. Over means that the extension of the denture is beyond the PPS area. So we have gone fovea palatini. When you take it as a landmark, say suppose, see, let me show you a maxillary cast. See, these are the fovea palatini. So these are the mucosal glands, right? Now openings, mucosal gland openings. So we have the PPS posterior to this fovea palatini. So when you make a denture up till the fovea palatini, that means the denture is going to be under extension, right? So most of the cases, fovea palatini, I mean the posterior vibrating line is beyond this fovea palatini. So don't take fovea palatini as a landmark when you are constructing the denture. So generally we take the denture at least 1 to 2 millimeters beyond this fovea palatini, and this is where the posterior palatal seal area is, right? Or posterior vibrating line is. So when you take fovea palatini as a landmark, that case the denture is underextended, because generally the fovea palatini is before the posterior vibrating line. Overextension is when you have extended the denture more posterior to posterior vibrating line. In that case, when the patient is having a functional movement, denture will fall, because it is again contacting the movable part of the soft palate. So soft palate will be moving and it will push the denture downward. Post dam, if it is under and over, that means, say suppose that's the polished surface of the denture, okay? So posteriorly, the posterior vibrating line is going to be thicker. So when it contacts, I have drawn opposite. So let's see if it is a maxilla, okay? Say suppose that's the maxilla. Now this denture is going to be pushing into the tissues, right? So that is how we give maxillary denture on the tissues. So as you can see, now again I am going to draw the mucosa so that you see what is the extension of the mucosa. So that is the mucosa, right? Posteriorly, we are going to push it towards the tissue so that we create a seal, right? So we are going to push this denture base posteriorly. That is a post dam, we say. Over means that you have made it so thick. So that is going to be over post dam. Under means this is mucosa and you have touched only till the mucosa. You have not created proper post dam. So that is less post dam you have created. So that is a under post dam. So Under extension is when you take fovea palatini as a landmark. So what happens when the patient is gagging while taking a PPS? So sometimes when the patient is gagging, you are not able to go more posteriorly. That is why you made it under extension. The most common cause is the failure of seal. So what happens when there is a under extension? There will be lack of retention. So failure of seal of the denture is what you see. Overextension is you see in some areas. For example, somewhere it is overextended. When the pterygoid humulus is not covered, if it is covered, then there will be pain during functional and difficulty in swallowing with the patient. So basically, when you go beyond the posterior vibrating line, then it is overextended. Under post damming is, see, when the patient opens the mouth wide, in that case there is under post damming. So check with a wet denture. If there are bubbles, that means under post damming is there. That means there is some air, there is not tight seal. So you scrape the cast more and then make it thick posteriorly, right? So that is how you correct the under post damming. So that is because of the under scraping. You have not scraped the cast. Use fluid wax technique so that with the wax you can record the PPS nicely. Over post damming is when you have too much scraped the master cast. In that case, there is very thick denture base present at the posterior area, so that is over post damming. So I hope that you have understood now the under extension and the under post damming. Both are different things. One is the extension posteriorly, another one is the thickness we are talking about. So thickness is when we are talking about post damming, over and under. Over means more thick we have created. Too much of scraping, that means more thick is the denture base. So if there is a moderate scraping, then the tissue irritation, we see displacement of too much tissues if in case of pterygomaxillary seal. And how do we correct it? Reduce the area. So we reduce the denture thickness. PPS 2, if it is present too deeply, then there is displacement of the denture anteriorly. So the denture is displaced anteriorly if PPS is too deeply. Next is hamular notch. So hamular notch is a depression present between the distal tuberosity and the hamulus of the pterygoid plate. So medial pterygoid plate and the distal tuberosity, there is a depression present. So this particular depression is going to be our hamular notch. So it's a depression present between distal tuberosity and the hamular process of the medial pterygoid plate. So it marks the distal posterior border of the maxillary denture. So this depression is where the distal part of the denture base ends. So it marks the posterior border of the maxillary denture. Remember, if they ask you a question, what marks the posterior border of the maxillary denture? It is hamular notch. Fovea palatini are the mucosal gland openings. They are present posterior to the hard palate. It is not present in every individual. So if it is missing, don't get worried. Denture should extend beyond 1 to 2 millimeters to the fovea palatini. That means here are the fovea palatini. After that, you should extend denture 1 to 2 millimeters. So remember that your denture base should always have these markings of the fovea palatini. If it is present, not used or only used as a guideline for the PPS. It is not used, never used as marking for the posterior border. So support of the maxilla is via the palatine bones and the palatine process of the maxilla. So what supports the maxilla is the palatine bone and the palatine process of the maxilla. Talking about the mandible, we have support areas, buccal shelf area and residual alveolar ridge. So these are the support areas. Crest of the residual alveolar ridge is a relief area. Remember, crest means the top part of the ridge. So that is the crest. But if we talk about residual alveolar ridge, that is not specifically talking about the crest, right? So supporting areas, buccal shelf area, which is also known as external oblique ridge. So there is going to be increase in the resorption. No, sorry, there is going to be reduced resorption in buccal shelf area. There is less amount of resorption. It lies perpendicular to the occlusal forces. So in general, see, this is a buccal shelf area. And remember, when we talk about posterior lateral slopes of the maxillary residual ridge or maxillary tuberosity, or the maxillary ridge, sorry. So posterior lateral slope of the maxillary ridge is a support areas, right? Also the buccal shelf area, which is again the lateral slope of a ridge, is also posterior lateral slope of the ridge is also a support areas. So average buccal shelf area is present 4 to 6 millimeter in a normal individual. If the buccal shelf area is narrow, in case of resorbed ridge, sometimes we see the buccal shelf area is very small. In that case, it is going to be 2 to 3 millimeters. Again, can be asked in question. So buccinator is going to reduce the resorption, and that is the reason that buccinator muscle is present, and that is the reason that there is reduced resorption in case of a buccal shelf area. When you see this buccal shelf area, now say suppose that's the crest of the ridge, and here is the buccal shelf area present. So the crest of the ridge is going to be, as you can see, this is a buccal shelf area, okay? So the crest of ridge is going to be mesially, right? This is the midline. So also the retromolar pad is going to present distally to it. And you can see the external oblique ridge will be lateral to it. So you know the landmarks now. Talking about the relief areas in the mandible, we have crest of the ridge. So crest of the residual ridge. For maxilla, it is a secondary stress bearing area. For mandible, the crest of the ridge is a relief area. Always remember this fact. What are the relief areas? Again, very important. The mental foramen is again a relief area. Then we have genier tubercle, a relief area. Also the tori, which is present in the mandible, known as torus mandibularis, which is present in the premolars, lingual to the premolars, mandibularis, and they are surgically removed, are the relief areas. When we talk about the limiting structures of the mandible, we have the labial frenum, which is an active frenum. Now in the mandible, the labial frenum is an active frenum because of the orbicularis oris muscle activity, and it becomes narrow on wide opening the mouth. So retromolar pad, which is this pad, it is a pear shaped pad, okay? And the retromolar pad is given by Syker, and the pear shaped pad term is given by Craddock. So this is a retromolar pad area. What are the extension or the landmark of this retromolar pad area? First of all, say this is a retromolar pad area. So distal end of the denture base, mandibular denture base, will be 2/3 of the retromolar pad. So basically the distal extension is going to be up till here, like this, somewhere 2/3 of the retromolar pad area. So in this retromolar pad area, posteriorly, you see the temporalis muscle activity. So temporalis is present posterior to this retromolar pad area. Say suppose that's a retromolar pad area. Here is the tongue. Okay. Then we have laterally buccinator present. So buccinator is going to be this side, buccal side. Then medially we have pterygomandibular raphe present, that is towards the midline, and also superior constrictor will be present medially. So the main objective of this retromolar pad area is retention of the denture, mandibular denture. So retention of the maxillary denture is via the PPS. Retention of the mandibular denture is via the retromolar pad area. Also, along with the retention, it provides stability of the denture. But the main objective of recording a retromolar pad area is the retention of the mandibular denture. Now, the patient is asked to close the mouth forcefully while the dentist apply pressure on the lower anteriors. So you apply pressure on the lower anterior teeth and ask the patient to close the mouth forcefully. It is done to record the masseter muscle activity, medial pterygoid. Basically, this particular kind is via recording the masseteric notch. So the action of masseter on the buccinator muscle is that what we record, right, in the mandible. And that is why we do this kind of movement. So it is going to record the action of masseter muscle on the buccinator, medial pterygoid, and the retromolar curtain area. Then retracting the cheek and moving upward and inward is done to record the buccal shelf area, or you can say the distobuccal sulcus. The action of medial pterygoid is recorded when we ask the patient to close the mouth forcefully against the resistance. Now, in case if the patient is having a knife edge ridge, so knife edge ridge is kind of like this ridge. In that case, we provide a broad or large surface area for the denture. Retention of the mandibular denture is via the maximum bone coverage. So snowshoe effect, right, which provides the stability. Bone coverage, that is going to provide the stability. Then the retromolar area should be covered. Otherwise, there will be ridge resorption and poor stability of the denture. The most important factor for the retention is peripheral seal, guys. So the most important factor for the retention is peripheral seal, and secondary retention is via anterior lingual border. So most important factor for the retention is peripheral seal, secondary retention is anterior lingual border. Retention for the maxillary denture is interfacial surface tension. Remember this point, very, very, very important. Retention for the maxillary denture. See, most important factor for the retention of the mandibular denture is peripheral seal. Secondary retention is via the anterior lingual border. For maxilla, it is interfacial surface tension, guys. Saliva, if it is present thin and even, it is good for the retention. Also, large surface area of the denture provides good retention. Then good adaptation is the capillary action. If the saliva is thick pasty saliva, that is because of the sympathetic stimulation. Watery saliva is via the parasympathetic stimulation. That is we have talked about in pharmacology. So excessive thick ropey saliva. If there is, when you take out the denture, there are ropes coming, right? Or when you take out the impression, there are ropes. So excessive thick ropey saliva, or if there is lack of saliva or xerostomia, there is going to be reduced retention of the denture. If the mucosa is thin in the maxilla, that is present in the torus palatinus, that is tori present in the maxilla, it is going to have a thin mucosa. Also, the median palatine raphe will have a very thin mucosa. In the mandible, if tori is present, then also it will be having a thin mucosa, and mylohyoid ridge will also have a thin mucosa. They can ask you which of the following structures will have thin mucosa. Then we have the theories of impression making, the mucocompressive theory, which is given by Charles Jones. So Carl Jones. So C for muco means mucosa, C compression, right? And then you can remember it, Carl Jones. So from C you can remember. Then according to this mucocompressive technique, the impression is going to be compressing the mucosal tissues. So when the impression compresses the mucosal tissues, the impression is going to be functional and displaced. Since it is a functional impression, because we are displacing the mucosal tissues, so the displaced impression is what we get. The material most commonly used for making this impression technique, that is mucocompressors, is the impression compound. Again, remember, C for compound, C for Carl Johns, and C for mucocompressive. So if you have taken impression from impression compound, it is going to compress. So you tightly press this impression compound against the tissues, right, when we are taking impression. So that is why you are tightly compressing it, displacing the tissues. It's a functional impression, mucocompressive technique. Also, mucocompressive technique is used with waxes, soft liners, elastomers, zinc oxide eugenol paste, and constant pressure is applied when you use this impression compound technique, and therefore when you are putting too much of pressure, there is going to be increased residual ridge resorption. So when you are using this impression compound alone, after that we use the selective. Okay, in the diagnostic impression, we take using the impression compound for a complete edentulous, that is a CD patient. So when you are taking this kind of impression and without taking a secondary impression, you make a complete denture on this impression compound or completely displaced or mucocompressive technique, there will be increase in the resorption of the ridges of patient. So there will be increased resorption if you use this technique, because you're constantly putting pressure, right? So because of that pressure, there is going to be ridge resorption. Mucostatic means mucosa are going to be static. That means in its place. You're not displacing the tissues, you're not displacing the mucosa. So mucosa is static, that means mucosa is as it is. So that is why it is a passive impression, because there is no pressure applied. It is given by Richardson and popularized by Henry Page. So remember, P for passive and P for Page. So Henry Page is one who popularized this mucostatic impression technique. There is no border molding in this case. We use the oversized tray. We take the impression in a relaxed state. So there will be poor retention of the denture since we take this impression in a passive state. So the mucosa are not compressed, right? They are slightly sitting on the mucosa. In case of maxillary, the denture will fall. So there is going to be poor retention since we are not displacing the tissues. Also, the stability in this particular case is going to be good. So good stability, but poor retention in case of mucostatic or passive impression technique. The material which we use is the impression plaster. So basically it's like a plaster, but we use for taking impression. Selective pressure technique is when we apply pressure on stress bearing area and we relieve the relief areas. So the impression material is going to be zinc oxide eugenol impression material. The secondary impression which we take is our selective pressure, because we take wax spacers, we apply in the areas of relief area. And if you remember, the wax spacer is applied in the incisive papilla, mid-palatine raphe, and all these are the relief areas, right? So we relieve the relief areas. Also the cuspid eminence we are going to relieve via the wax spacers. So we relieve the relief areas and we put pressure on the pressure bearing areas. That is the selective pressure technique. We use zinc oxide eugenol or medium body elastomer. So it is introduced by Wilson in 1920 and advocated by Boucher in 1943. So what if you take a oversized tray? Then there will be distortion of the tissues. The tissue will distort around the borders of the impression. Say suppose if you are taking a big impression tray compared to the size of the ridge. So if you take too large tray, then there will be, since the tray is too large, so the border of the tissues will distort. If you take small trays, that means the border won't be covered from the impression tray. So the border tissue will collapse inwards into the ridge. So there is going to be reduced support if we take a small size tray. What are the objectives of impression is retention, stability, support, and preservation. So retention is a mucosa bond. Since we compress the mucosal tissues, therefore we get the retention. So resistance to the displacement away from the tissue surface. So that is retention. Support is from the occlusal forces. So it is a bone-borne phenomena. So mucosal bone phenomena is retention and bone-borne phenomena is support. So we get support via snowshoe effect. So that is why more the bone coverage, more is going to be support. So snowshoe effect. So snowshoe effect provides support. Remember all these points because they ask you that snowshoe effect provide which retention, stability, support and preservation. So remember that it provides support. Then we have stability. Stability is provided via lateral or shifting forces. So all the lateral forces, it provides resistance, lateral shifting, or you can say anterior posterior shifting. Then there is preservation of the structures. Now atmospheric pressure, also known as emergency retentive forces, also known as temporary restraining forces. So instead of giving the term atmospheric pressure, they can give you emergency retentive force or temporary restraining force are 14.7 lbs per square inch. So remember the word 14 centimeter square is the mean denture area for the edentulous mandible and 14.7 is the atmospheric pressure. So 14.7 lbs per square inch is the atmospheric pressure and 14 centimeter square is the denture base area for the edentulous mandible. For the maxillary arch, edentulous maxillary arch, it is 24 centimeter square is the mean denture base area for a edentulous maxillary arch. So for mandible, 14 centimeter square is the surface area for the edentulous mandible and 14.7 is the atmospheric pressure. So coming to the Atwood residual ridge resorption classification. So based on that, the first one we have before the extraction is the pre-extraction. Then we have, this is the extraction socket, that is post-extraction. The third one is very good for retention. What we talked about is high well-rounded ridge. So high well-rounded ridge is very good for the retention of the denture. Then we have, that is a class 3. So remember class 3 is best for the retention. Then always remember that how the ridge resorb is, first of all, there are sides resorption. Then the bone resorption will be from anterior. So first there is buccolingual resorption and then there is resorption or reduced in the height. So first there is reduction of the width, then there is reduction of the height. So then we have a knife edge ridge, that is class 4, knife edge ridge, and class 5 is a low well-rounded edge, low well-rounded, or you can say a flat ridge. Then we have a depressed ridge. So first of all, there is a buccolingual reduction, then there is occlusion gingival or reduction in the height. So first reduction in the width, then reduction in the height. In case of severe residual ridge resorption, the gonial angle is going to be small. So first year after extraction, the amount of residual ridge resorption we see in the maxilla, it is 2 to 3 millimeters, and we know resorption is more in the mandibular arch. So in the mandible, it is 4 to 5 millimeter 1 year after extraction, and later on in the mandible, we see 0.1 to 0.2 millimeters in the mandible, and in the maxilla, it is 4 times lesser as compared to the mandible. So after residual ridge resorption, we see widening of the mandible and narrowing of the maxilla. So the mandible becomes wider and the maxilla becomes narrower. Therefore, the patient is having a prognathic profile after a residual ridge resorption. So they ask you what kind of profile a patient develops after having a ridge resorption, that is a prognathic profile. There is widening of the mandible, narrowing of the maxilla. the resorption in the maxilla is upward and palatal, and that is why it becomes narrower. In the mandible anteriorly, there is a resorption in downward and lingual, and that is why the mandible becomes widens, right? Posteriorly, it is downward and buccal. So basically, say suppose that's a mandible, right? So anteriorly it is downward and lingual, posteriorly it is downward and buccal. So therefore the mandibular arch becomes wider. So this is a chin which deformity. This particular deformity is a chin which deformity, and that is because of post-operative complication when a mucoperiosteal flap is raised in the symphyseal area. So during the border molding, the distobuccal extension is recorded via the mesenteric muscle. Distolingual extension is via superior constrictor muscle. So they ask you this particular kind of question, that distobuccal extension is via which muscle? Distobuccal extension is via the masseter muscle. So the action of masseter over the buccinator is what we see in as a mesenteric notch, which is recorded in the mandible. So during border molding, mesenteric notch is recorded in the distobuccal flange area. In the mandible, that is because of action of masseter via the buccinator. So that records the distobuccal extension of a mandibular denture. And distolingual extension is recorded via superior constrictor muscle. Then talking about the maxilla, we see pterygomandibular raphe that connects between the buccinator and the superior constrictor. So in the maxilla, we record the coronoid notch. That is again in the distobuccal flange area. So this particular area, distobuccal flange area, and we ask the patient to rotate the jaw right and left, right? And that is how we are going to record this coronoid notch in the maxilla. In the mandible, we record the masseteric notch, and that is again in the distobuccal flange area, action of masseter on the buccinator. We ask the patient to open the mouth against the resistance, and that is how we record this masseteric notch in the mandible. So in the maxilla, coronoid notch; in the mandible, masseteric notch. Always remember this fact. And retromolar pad marks the distal extension of the mandibular denture base, and hemular notch marks the distal extension of the maxillary denture base. So retromolar for the mandibular arch, it provides support as well as retention. Most importantly, it provides retention. The main principle is via providing the retention. Attachments of the retromolar pad is via constrictor and pterygomandibular raphe, right? So pterygomandibular raphe, we have two muscles, buccinator and superior constrictor. So we are already done with three: buccinator, constrictor and pterygomandibular raphe. Another one we have is the temporalis. Then in the mandible, labial vestibule, we have mentalis activity, and buccal vestibule, we have buccinator, and labial frenum orbicularis oris. Now hinge movement is the pure rotation. Hinge is always a pure rotation movement, guys. This is a glenoid fossa, that is a condyle. So when the condyle moves just to and fro, that is just going to rotate in the glenoid fossa, that is going to be a hinge movement. So when you open the mouth from 20 to 25 millimeter, so when you open up till 20 to 25 millimeter, that is going to be 2 centimeter, 2.5 centimeter, there is rotation of the condyle, that is a hinge movement. And when you do this movement, the rotation of the condyle is 10 to 13 degrees rotation. So they ask you such kind of questions that hinge movement or pure rotation is from 20 to 25 millimeter of the mouth opening, and the rotation is 10 to 13 degrees of the rotation of condyle. The rotation around the transverse or hinge axis is, this is a transverse from one condyle to another condyle, is this one is the transverse of hinge axis. When you rotate it, when you rotate the mandible like this, so there is going to be protrusive movement, protrusion. Then talking about the lateral movements, say suppose if the movement is towards this side, this is a lateral side. If the movement is towards the same side, that is left, lateral, instead of lateral it is left. This is the left side. If the movement is towards the same side, that is the left side, then it will be called as the working side. So the movement is just outward. That is, the movement is going to be like this. If the movement is on the left side, the other side is known as non-working side. So if the movement is towards left side, then right side will be called as non-working side or the balancing or idling side. So working side is known as the rotating condyle. Non-working side is known as the balancing or idling condyle. So the right side movement is going to be downward, forward and inward. So the net movement will be like this. So downward, forward and inward for the non-working side, or we can say balancing idling side. Outward movement will be working side, that is known as the rotating condyle. So here we see Bennett movement, and this side we see, the non-working side we see Bennett shift or Bennett angle. So Bennett movement is towards the same side, that is the working side or the rotating condyle. Here we see Bennett movement. So how much the condyle or the mandible is going to move on the working side is only 1 to 1.5 millimeter. But the movement on the other side, that is going to be the Bennett shift, it is 1 to 4 millimeters, that is more. So the working side, the same side is the rotating condyle. The movement is the Bennett movement. So the working or the rotating condyle we have is the Bennett movement, which is the outward movement, and it is from 1 to 1.5 millimeters. The non-working side, also known as balancing or idling side, we have downward, forward and inward. In this we have the Bennett shift. Bennett shift is from 1 to 4 millimeter. So the Bennett shift is of three kinds: immediate, procurrent side shift and progressive or Bennett side shift. So immediate shift is when there is lateral translation from 2 to 3 millimeter, and then there is a forward translation, that is an immediate shift. Procurrent side shift is when there is rapid lateral movement and there is less rapid or slow lateral side movement. Progressive side shift is, it is progressive, or Bennett side shift is when there is linear lateral translation up to 4 millimeters. Bennett angle is generally 7.5 to 12.8 in normal individuals. In articulator we keep 14 degrees, but in Hanau average is 30 degrees. And how do we calculate Bennett angle in the Hanau articulator is with the formula L is equal to H by 8 plus 12. That is how we calculate the Bennett angle in Hanau articulator. Movement in the horizontal plane is, say suppose this is the centric relation of the patient. When we ask, this patient is wearing a Gothic arch tracing. When we ask the patient to protrude the mouth, when the patient, this is side view guys, when we ask the patient to protrude the mouth, that means take the mandible forward, the mandible will go like this. So there is going to be forward movement of the mandible. So the forward movement of the mandible will be a protrusive movement. Then we ask the patient to go back to the centric relation again. So the patient is in the most comfortable position. Then we ask the patient to take the mandible left side, take the mandible right side. So joining these dots will give us a diamond tracing. So left lateral, right lateral. So this is a diamond shape. So this tracing is known as a diamond tracing in a horizontal plane. So in this plane, when you calculate it, centriculation is this. Protrusive will be forward. Again back to the centric. Then right and left. So that is how there is going to be movement in the horizontal plane. And how you can remember is horse diamond. With a horizontal, it is diamond tracing. So the people who go to see horse racing wear diamond ring or they have diamond, they're very rich. Frontal or coronal or vertical, see in this frontal plane or this vertical plane, the centric relation is going to be like this. This is the centric relation. Then we ask the patient to take the mandible. This is a vertical plane, guys, this vertical plane, right? This is going to be left, this side is going to be right, and down. When the patient opens the mouth in the vertical plane, it will go down, the mandible will go down. In this plane, when the patient opens, it is going to be like this. So that is a shield tracing. In case of frontal or coronal or vertical. In sagittal, there is a beak tracing. So you can remember Sagittarius girls are beautiful. So beak tracing in case of sagittal plane. Then envelope of motion is given by posite. And see, the posite envelope of motion, it's a 3D. This is a centric relation. Okay. Then the patient from centric relation close the mouth. So that is going to be maximum intercuspation, tightly closing. Then the patient protrude the mouth. First of all, edge to edge and then protrusion. So this is somewhere edge to edge, then the protrusion. Then when the patient opens the mouth, mouth goes like this. So that is, this point is going to be maximum opening of the patient. Then somewhere here is the terminal hinge axis and then the centric relation. So this is the envelope of motion. Chewing cycle is how you chew. Take the mandible and the chewing cycle is like this. So it's like a teardrop. Chewing cycle is teardrop shape. So vertical dimension is this height. When it is increased, that means you have given longer. The patient's mouth is going to stretch like this. And when you reduce the vertical height, the patient will have like this. That means there will be folds. So if the vertical height is increased, then there will be cheek biting. The patient mouth will be stretched and elongated. You know, the lower facial height will look like it is stretched and elongated. And there will be difficulty in speech and swallowing. Difficulty in speech and swallowing because the face has elongated and swallowing. So the patient mouth will be like this. Also there will be TMJ pain and TMJ clicking sound when the teeth contact. Like there will be clicking sound. Because you have reduced this freeway space, so therefore the patient's teeth will contact frequently. So there will be clicking sound from the contacting of the teeth. If you have reduced this vertical height, that means the patient mouth will be like this. So there will be folds at the corner of the mouth, and these folds will lead to angular cheilitis and stomatitis, angular stomatitis, because saliva is going to accumulate over these folds. Therefore, there will be recurrent infection. Also, when you have reduced this vertical height, there will be elevation of the tongue or mandible. Also, there will be elevation of the soft palate, and this will create obstruction at the eustachian tube. When we talk about centric relation, we know it is bone to bone contact, right? When the condyle is in retruded contact position, that is the previous definition. That means when the condyle is in the glenoid fossa and when it is at the most retruded contact position, that is the centric relation. Remember, centric relation is always bone to bone contact. It is not teeth to teeth contact, it is bone to bone. When we talk about the condyle and the glenoid fossa, that is what centric relation is. So retruded contact position, that is a previous definition. Current definition says when the condyle is present most anterior superior. So archon type of articulator, that means it is articulated like the normal condyle of the individual. So that means condyle will be present. So these are the condyles. They will be present in the lower member, and the condylar guide, which is basically guide like a glenoid fossa, it will present in the upper member. And such an example of archon type is Barome articulator, or given by Barome. And the examples of archon type articulator are knee articulator, telident articulator, and whip mix. Remember that the Hanau articulator is a non-archon because Hanau works opposite to the normal individual. So the condylar analog, that means the condyle, something which looks like a condyle, analog means which mimics. So condyle is present in the upper. Generally in the patient or in the normal individual, condyle is present in the mandible. It is a part of mandible. When it is present in the upper, then it is a non-archon. That is, it is not mimicking the normal. So condylar guide is present in the lower, which is opposite to the archon is the non-archon. Examples of non-archon are Hanau, dentitus, and Geissi articulator. So now talking about the curves. Curve of Spee is given by Graf von Spee, and basically it is a curve starting from the cusp tip of the canine, cusp tip of the premolars and molars, and up till the anterior border of the ramus. So this is a curve of Spee. Posterior teeth should follow this curve during the protrusion. So when there is a protrusive movement, the posterior teeth follow this curve. Then we have this cusp is the this curve is the curve of Wilson. So this is a curve, this curve, and we arrange molars in balanced occlusion in curve of Wilson. Then we have curve of monsoon, which makes a sphere with the center at the glabella of 8 inch in diameter. So basically curve of monsoon is curve of Spee plus curve of Wilson. Reverse curve or anti-monsoon curve is used when we arrange the first premolars. So this particular curve is curve of monsoon. Then we have the pleasure curve. So pleasure curve is this when the mandibular teeth slopes facially and it is seen during excessive tooth wear. So the flat or cusp, you can see these occlusal surfaces are cooped out. So that means they are atreated. They have become flat. So when there are flat or cupped out occlusal surfaces of premolars and molars, premolar, first molar, and second molar. When the mandible teeth slope facially, as you can see, these mandibular teeth are sloped facially and the maxillary teeth are inclined lingually. So it is used as a combination of monsoon and anti-monsoon curve, and it is used to arrange the non-anatomic teeth. Non-anatomic teeth are cuspless teeth. As you can see, they have got cuspless teeth. Non-anatomic teeth in balanced occlusion. So in that case, we use this pleasure curve. So non-anatomic teeth in the balanced occlusion, the premolars and first molar are arranged in reverse curve, that is to promote the buccal tipping and basically to seat the denture. And second molars are arranged in a conventional monsoon curve. So premolars and first molar in the reverse curve and second molars in a conventional monsoon curve to prevent the eccentric lateral balance. So the factor which favors disocclusion. So disocclusion is when there is no contact in the posterior teeth. That is a steep, all the guidance are steep. Steep incisal guidance, condylar guidance and the canine guidance. Rest everything is less or short. So remember all the guidance. See, this is a frequently asked question, that factors which favors disocclusion. Disocclusion is when there is a eccentric movement, that is a lateral movement, there is no posterior tooth contact. So what are the factors that create this separation of the posterior teeth during the eccentric, that is right or left lateral movements? In that case, the posterior teeth are not contacting, and what are the factors which make this space or gap at disocclusion? So all the guidance, when they are steep, there is going to be disocclusion, because when there is a movement, since the angulation is very steep, so there will be posterior space. So posterior disocclusion. Steep incisal guidance, condylar guidance and canine guidance. Rest all the factors are either shallow or they are short or less. So there is less Bennett movement or less side shift also creates disocclusion. There is short cusp with shallow inclines also create this disocclusion. And when there is less curve of Spee and Wilson creates disocclusion. Occlusal plane is less parallel, then it will create the disocclusion. So remember, steep inside all the guidance, incisal, condylar, canine, rest everything is less or short. Sore spots are dislodgement. Sore spots are basically the ulcers, that is because of the overextension of the denture, and generally after giving a denture, after 1 week, we recall the patient for follow-up, that is to check if there is any overextension or sore spots present. And lack of retention is because of the underextension of the denture. Best indicator for the denture success is the ridge, alveolar ridge. Monomer is to polymer, that is liquid to powder. If we take by volume, it is 1:3. And if we take by weight, this is by volume. And if we take by weight, it is 1:2. So that is monomer is to polymer. And if we heat the acrylic too rapidly, then there will be porosity. Hue is the quality or the shade of the color. Basically, the color is the hue. Chroma is the intensity or saturation. And value is lightness or darkness, or black or white, you can say. Then we have Hanau's squint. We have 5-factor: condylar guidance, incisal guidance, how the condyle is guided, how the incisal teeth are guided, what are the compensating curve, the curve of Spee, relative cuspal height, what is the height of the cusp which we give, and the plane of occlusion, how is the plane of occlusion. These are the 5 Hanau squints, and the Tilsman formula is upper 2. So both the guidance divided by lower 3. So we have condylar guidance into incisal guidance. All the guidance are upper and rest everything is lower. And remember, I told you, if disocclusion means all the guidance are going to be steep, everything is less or shallow. So that are the factors that are going to promote the disocclusion. So Tilsman formula, condylar guidance into incisal guidance divided by compensating curve into cuspal height into plane of occlusion, occlusal plane. So condylar guidance is how the condyles are guided. Say suppose that's the glenoid fossa. We have this is the condyle. Up to 20 to 25 millimeters of the mouth opening, there will be pure rotation. Or we can take 10, we can say 10 to 13 degrees rotation of the condyle. After that, there is going to be protrusive movement. See, this is a centric relation. The teeth will be like this. Anterior teeth are going to be maxilla and mandible. When there is a protrusion, generally what we see is this is the space which is present posteriorly. Once you protrude the mouth, see there is posterior disocclusion in say suppose edge to edge. And this particular phenomena is known as Christensen's phenomena. So how the condyles, see this is the condyles, how this bone is arranged, that is going to be a condylar. How this condyle moves is based on this angulation of the bone, right? Articular eminence. How this articular eminence is based on that the condyle is going to slide over the articular eminence, right? During protrusion. So this is how the condylar guidance is to be. And this is the only factor which is not under the dentist control because this is based on the slope of the morphology of the articular eminence. So basically during the protrusion registration, we see the condylar guidance. Incisal guidance is how the incisal teeth are guided. Say suppose this is the CR. Now this mandibular teeth is going to slide through this teeth and come and sit here. So it is going to be sliding over here and it will stay like this. So this particular slide or path is known as incisal guidance or the protrusive path. Now what if there is a steep incisal guidance? If there is a steep incisal guidance, you can say we have increase in the overjet. Overjet is the vertical distance. Overbite is the horizontal distance. There is going to be increase in the overjet. Overjet is the horizontal overlap, right? The horizontal. Overbite is the vertical. So when there is a steep, this is a basically steep incisal guidance. Then here in this particular diagram, you can see moderate. This particular diagram, as you can see, there is increase in the horizontal overlapping. So increase in the horizontal overlapping, basically more overjet, right? So increase in the overjet, there is going to be decrease in the incisal guidance. As you can see, the guidance here is lower. So if there is increase in the overjet, increase in the horizontal overlap, we have to give a shallow or flatter cusp. And there is going to be decrease in the incisal guidance. As you can see, the guidance of the incisal is decreased. As you can see here, we have a steep incisal guidance, but this time, this particular diagram, we have a shallow incisal guidance or decreased incisal guidance. So if there is increase in the overjet, then there is decrease or shallow incisal guidance. Plane of occlusion is the plane that touches all the occlusal surfaces. So this plane should not be tilted more than 10 degrees. This is the occlusal plane and it should not be tilted more than 10 degrees to the alatragus line. Now the occlusal plane for the posterior teeth is 1/3 to 2/3 of the retromolar pad area. So this is the total height. It should be 1/3 to 2/3 of the height of the retromolar pad. And extension, posterior or distal extension of the denture base is going to be 2/3 of the retromolar pad. Compensating curve. Anterior posterior curve is the curve of Spee. And lateral curve we have is the curve of Monsoon, curve of Wilson, and pleasure curve. So steep condylar path. This is a steep condylar path. Steep condylar path, when there is, then if the condylar path is steep, the compensating curve will also be steep. There will be prominent compensating curve if the condylar path is steep. So we give low degree of incisal guidance in this particular situation. Then talking about the classification of the articulator, the first one, there is only vertical movement, that is only opening and closing of the articulator. In case of a simple holding instrument is a class 1 articulator. So here this particular diagram is a slab articulator. This is a hinge articulator. Both are class 1 articulators. Other example of class 1 articulator in which there is only vertical movement is barn door or hinge, Geissy and Garriott. Class 2 articulator is when there is, first of all, see, class 1, there is only one. Class 2, we have A, B and C. Class 3, only A and B. And class 4, also A and B. So class 2, we have three subtypes, A, B and C. A is average or arbitrary values, B is based on the theory, and C is based on the patient. So eccentric motion, A, is based on average or arbitrary value. In that we have mean value articulator, in which we take mean values and we have made this articulator. Theories of arbitrary motion, we have three theories. Bonville articulator based on the Bonville theory. So Bonville articulator based on the Bonville triangle. So this is an equilateral triangle of 4 inch from the condyle up till the cusp tip of the lower anterior. Then the another theory is the monsoon theory. Based on that we have spherical theory. So basically the monsoon articulator is based on the spherical theory. This spherical theory is based on a sphere with the center at the glabella, and we have 8-inch diameter. So that is a spherical theory. The third one based on the theory we have is the Hall's articulator. So from the cusp tip to the incisal articulator, from the cusp tip to the incisal edges makes an angle of 45 degrees. So that is Hall articulator. So based on theories, we have Bonville articulator, monsoon and Hall's articulator. Now determined by the patient using engraving method, we have House articulator. So next one is the third one. So basically first one is based on the vertical, second is vertical plus horizontal movement, and third one is we have the example as Hanau. So first of all, third A, we have static protrusion. In the static protrusion, it is non-archon, examples being Hanau, H and dentitus. Static lateral, we have archon type articulators like Ne and Telident. So archon is the static lateral, non-archon is the static protrusion. In the non-archon, we have example as Hanau. In that we take a static protrusion record. It stimulates the condylar paths and allows the orientation via a phase bow record. Type 4A is the condylar path, cannot be modified like a TMJ articulator and a stereograph. 4 type B is custom condylar path we create like a pentograph or dinar or Stuart instrument gnethoscope. So this is basically using a 3D registration record, that is a type 4 articulator. Cephalic index is when width of the central incisor is we take according to the size of the face. So according to the size of the face, we take width of the central incisor. So anthropometric measurement, we have width of the central incisor is equal to circumference of the face divided by 13. Berry's biometric index. So B for Berry's biometric index and B for bizygomatic width. So width of central incisor is equal to bizygomatic width divided by 16, length of the face divided by 13 gives the Berry's biometric index. Vertical height of the face is determined by using a Will's gauge. Then we have difference between a cuspless teeth or 0 degree or non-anatomic teeth. And then we have a semi-anatomic or low cusp teeth or 10 to 20 degrees. So cuspless teeth is basically a teeth like this in which there are no cusp. These are the posterior teeth with no cusp. So first cuspless teeth was inverted cusp teeth or Hall's teeth. And these kind of teeth are indicated when the ridge is resorbed. So flat, atrophic, resorbed ridge, knife edge ridge. And in case if the patient is having Parkinsonism or any neuromuscular disturbance, we give the cuspless teeth. In this, the balanced occlusion is as the centric relation, and we give anti-monsoon curve, and we give ramps, palatal ramps, so that there is a 3-point stop as palatal, as we give the ramps in the neurocentric occlusion. Semi-anatomic teeth, low cusp teeth, or 10 to 20 degrees teeth. So semi-anatomic teeth are basically these teeth with 20 degrees angulation. Non-anatomic teeth is the one with the 0 degree angulation, and anatomic teeth are the one which having 33-degree angulation. So semi-anatomic between 0 to 20, you can say somewhere around 20. 10 to 20 degrees, if the cusp is angulated, it is known as functional or entoline teeth. They are flexible to arrange. And if it is, generally it is 20 degrees, we say. So first semi-anatomic teeth is a channel tooth. In the maxillary, they have given grooves. And in the mandible, so basically the mandibular occlusal surface, if you see of these teeth, there are grooves present like this. And in the mandibular teeth, if you see occlusal surfaces, they have given ridges for the channel teeth. So limited lateral, L and unlimited protrusive movement. Scissor bite is just opposite to these channel teeth, because in the channel teeth there is LL, limited lateral, and in case of scissor bite teeth it is limited protrusive. Metal insert teeth or vitalium or hardy teeth, you see the vitalium ribbon in the occlusal surfaces of these metal insert or vitalium or hardy teeth. So occlusal gold teeth are the best teeth to be used against the natural, and 10 to 20 degree cuspal angulation is we call functional or entoline cusp. Anatomic teeth are 33-degree cuspal angulation. True bite indicator determines the size of the central incisor. You have to remember when I say size, when I say width, because sometimes they give you size, width. Like this, if they ask you in a question regarding the cephalic index, so they can say the size or length of the central incisor. They will give you option width of the central incisor. So you have to remember what part of central incisor we use as the anthropometric or Berry biometric, basically the cephalic index. When we talk about cephalic index, it is the width of the central incisor. When I say you true bite tooth indicator, it is the size of the central incisor. Leon William theory, Leon William gave the typal form theory. So based on that, based on the form of the face, say suppose if a person is having ovoid face, right? So in that particular case, we are going to give the ovoid kind of crown. So the size of, or I can say shape to be specific, shape of the face is equivalent to shape of the crown or shape of the teeth which we give, according to typal form theory. Squint test is when a dentist close the one eye and match the color of the teeth with the color of the face. We take 5 seconds to do this. Less than 5 seconds it should be. So squint test is immediately you match the shade. So basically it is for shade matching. So color of the teeth is matched with the color of the face. Translucency allows the light, and enamel have got high brilliance and high translucency. Dentogenic concept is based on the selection of the teeth. We have SPA factor. So sex, personality and age. So based on the sex of the individual, we give the teeth. So if a person is having a, say suppose male, so it will have very sharp edges teeth. If it is female, slightly round edges. So like that, we select the teeth based on the age, based on the personality, and based on the age of the individual. If a person is more old aged, say suppose above 60 or 70 years, then we give more towards the flat teeth, because like a treated teeth it should give. So buccolingual position of the teeth, if we say anterior teeth is determined by the position of the canine. So buccolingual position, how are we going to determine for the from the anterior teeth from the position of the canine, and posteriorly from the shape of the basal seat area and the location of retromolar pad. When we say good aesthetic, how do we achieve good aesthetics in a denture is via teeth selection and arrangement of the teeth. Also, good aesthetics is established by adaptation of the border seal, and you can get all of the following except in this particular kind of question. So good aesthetics is observed by all except. So teeth selection gives us good aesthetic. Arrangement of the teeth also give good aesthetic. See, this is about the teeth. When we know teeth, it is related to the looks aesthetic. But also adaptation of the border seal areas and adaptation or adequate bulk of the maxillary facial flange gives good aesthetic, because it gives good gummy appearance. Neutral zone via buccinator muscle. Position of the tongue in relation to the teeth is recorded via 333. So when the tongue contact the teeth, we say the position of the via this 333 number. Silverman closest speaking spaces. It is a space when we are speaking, this space is present. So it is different from the freeway space. So freeway space is the space between vertical dimension of rest and vertical dimension of occlusion, right? But the Silverman closest speaking spaces, when we speak, there is a small amount of space between upper teeth and lower teeth. So it is a space that is present during functional or speech. So it is a functional space. It is a dynamic space. So this space is produced during the sibilant sound or S sound. So normally the Silverman closest speaking space is 1 to 2 millimeter. In class 3 individual, in class 2 individual, this space is more. It is 3 to 6 millimeter. And for class 3, it is less because mandible is prognathic, right? So there is less space in class 3, 0.5 to 1 millimeter. Linguo-alveolar sound. Linguo means tongue and alveolar means alveolus or palate. So when we say words like T, the tongue is going to touch the palate, T. So, or we say word D, S, Z, N and word like L. So these, when you pronounce it by yourself. So you will see the tongue is touching the palate. So it's a linguo-alveolar sound. Fricative words are also known as labiodental sound. So labio means lip when they are touching the teeth. So it is words like F and V, and they're very, very, very important for the exam. Labiodental sound determines the anterior posterior position of the maxillary teeth as well as the mandibular teeth. So basically what happens, these teeth are going to touch the wet and the dry line of the lower lip. So the wet part which is moist and the dry part which is not moist, the teeth are going to touch in between. So that is why we see how the maxillary teeth, if they are anteriorly inclined or they are posteriorly reclined. So these labiodental sound or the fricatives determine the anterior posterior position of the maxillary teeth. Say upper anterior teeth, if they are too short, that means this is the lower lip and it is not touching the upper lip. So if it is not touching, if the upper anterior teeth are too short, how you can remember is short viral film or short vulgar film, any of it. So short viral film, that means if the teeth are short, then V will be pronounced as F. So V will be pronounced as F. If the upper anterior teeth are short, V and F, right? If the upper anterior teeth are too long, that means they are going, this is a lower lip. The teeth are going to go more deep into the lower lip because the upper anterior teeth are long. So you can remember long film in vagus, that means F will be pronounced as V. If the teeth are too labially or anteriorly arranged, that means the upper anterior teeth are more like this. If they are more anteriorly arranged, then you can remember la beta dish TV. So that means la beta means labially. That means they are more anteriorly placed. In that D will be pronounced as T. If they are present more posteriorly or palatally or lingually, the upper anterior teeth, if they are placed more lingually or palatally, then T will be pronounced as D. So bilabial sound are when both the lips, bi means both, labial means lips, when the both lips are touching during the pronunciation of a sound, like the word B. Pronounce it yourself, word B. Both the lips are touching. So lip support by the denture flange is what we see. That means the denture flange are placed so that both the lips are getting adequate support in the word like B, P, M. Sibilant sounds are the sharp sounds. They are also known as alveolar sound. The upper anterior teeth, they are not touching the lower, but they are approximating to each other, such as S. When you say S, the upper teeth are not touching the lower teeth, but they are very close to the lower teeth. If you have reduced the VD, that means there will be upper teeth touching the lower teeth because the VD is reduced. So in that case, the person won't be able to pronounce S because you have reduced the closest speaking space. So basically the closest speaking space is determined by the sibilants, the word like S, Z, sh, s, and j. So all these words are known as sibilant sounds. If you reduce the gap or if you reduce the VD, there will be whistling sound like a whistle. S, s. They will say S, they will say S, S. Like that, there will be narrow and the whistling sound. If you reduce the VD, the sibilant sound will produce a whistle. If you increase the gap, then there will be, if there is a broad gap, there will be lisping. So S sound will be produced as esh, esh. Since there is more space, so there will be lisping sound that is seen in the sibilant or the lingo-alveolar sound, in which we determine the closest speaking space like S, sh, j, like all these sounds. So closest speaking space is the space which is left during speech or function. So it is 1 to 1.5 millimeter. Interincisal separation is this much. Between the upper and lower teeth, there is separation between 1 to 1.5 millimeter. Palatal sound, velar sound, or the vowel sounds have got no effect on the denture. Now talking about support. So supports provide resistance to the vertical seating forces. So the vertical seating forces on the denture. In the maxilla, support is provided by the palate, of course. We talked about maxillary support is via the palatine bone and the palatine process of the maxillary shelves. So palate bone as well as the alveolar ridge provides the support to the maxilla. So support is always via the, as I told you, support is always via the bone, right? So that is the support. Mandible, we have buccal shelf area providing support as well as retromolar pad. Retromolar pad basically principally provides the retention, but it also provides the support. Now talking about the stability, stability is provided by the horizontal dislodging forces, and the upper and lower denture stability is provided by the height of the ridge as well as depth of the vestibule. And the denture flange also provide the stability to a denture. Retention is via the vertical against the vertical dislodging forces. So the vertical forces that are going to dislodge the denture, and it is provided by peripheral seal. Remember, I told you primary retention is via the peripheral seal and secondary is anterior lingual border. So what are the denture problems and what is the cause for it? Clicking sound is produced when you increase the vertical dimension. When you increase the VD, there is less gap. Therefore, the clicking of the teeth is more frequent. So because there is less space between anterior and posterior teeth, the teeth contact very often. So cheek biting is seen when there is again increase in the VD because the mouth is very prolonged like this. So the cheek get coming in between and the patient get the cheek bite. Soreness on the crest of the ridge is because of the heavy occlusal contact which are coming on the crest of the ridge. Difficulty in swallowing we see with the increase in the vertical dimension. Because the vertical dimension is increased, the patient will have difficulty in swallowing and speech. Also, difficulty in swallowing is we see when the overextension of the lingual flange area into the lateral throat form. So soreness on the slopes of the ridge. See, soreness on the crest of the ridge is because of the heavy occlusal contact. Soreness on the slopes of the ridge is because of the deflective occlusal contact. Occlusal contact. Then denture, when you have fabricated it is tight. After some time the patient says that when I insert it, it is tight. But after some time it becomes loose. So that is because of the deflective occlusal contact. Pain and soreness on chewing is because of the occlusal interferences. And denture becomes loose on smiling, that is because of the inadequate buccal frenum relief. You have not relieved the buccal frenum. Denture become loosen when the patients open the mouth. When the patient opens the mouth wide, the coronoid notch is not recorded properly and there is more thickness in the distobuccal flange area of the maxillary denture, and that is the reason when the patient wide opens the mouth, denture become loose. So the coronoid process is not recorded properly and there is more thickness in the distobuccal flange area of the maxillary denture. Mucosal irritation is seen with the overextended borders. Burning sensation in the anterior 1/3 of the maxillary denture is because of the incisive papilla which is not relieved. Epulis fissuratum is seen with the ill-fitting denture. So loose tissues we see with the ill-fitting dentures. Now talking about occlusal interferences. If there are occlusal interferences present in the centric relation, anterior teeth, in the anterior teeth, then we reduce the incisal edge of the lower teeth. If the occlusal interferences are present in the centric relation in posterior teeth, then we reduce the fossa or the marginal ridge. So basically here incisal edge of the lower and centric posteriorly fossa or margin. Fossa or margin of the posterior teeth. Basically in the maxilla we reduce the mesial incline and in the mandible we reduce the distal incline. If there is interference present in centric as well as eccentric or lateral movement. In the anterior we reduce the incisal edge of the lower as well as we deepen the lingual fossa of the upper. If the occlusal interferences are present in centric and eccentric in posterior, so on the working side, we have Bull's law. That is buccal upper. So buccal inner inclines of the upper teeth and lingual inclines of the lower teeth. So buccal upper, lower lingual, both inner inclines. Working side is the Bull's law. Non-working or the balancing or the idling side, we have BULLLB. So remember one thing, the centric holding cusp are palatal cusp of upper, buccal cusp of lower, we know. So the centric holding cusp opposite inclined. Remember, for balancing or non-working side, the centric holding cusp opposite inclined. That means the palatal cusp of the maxillary is the centric holding cusp. The opposite incline is the buccal incline of the palatal cusp of upper. Then we have buccal cusp for the lower, that is the centric holding cusp. So the lingual incline, that is the opposite incline for the lower buccal cusp. So how you can remember is opposite incline of the centric holding cusp. So buccal incline of the palatal cusp of upper, lingual incline of the buccal cusp of the lower. Remember, the centric holding cusp are never grinded, especially the primary cusp, which is the palatal cusp. So the palatal cusp is never grinded. And the secondary cusp is the buccal cusp of the lower. Then we have the combination syndrome, in which maxillary, the patient is having a complete denture, and the mandible, we have RPD with a distal extension. That means teeth are only present in the mandibular anterior part. Distal extension in the RPD. So denture appointment in the asthmatic patient is given in the afternoons. Then masticatory or the biting forces in the maxillary teeth are 600 newtons. If they give you in kilograms, 20 kgs, a natural teeth can take up masticatory load. That means you can chew up to 20 kgs or 44 pounds. For CD, it is 110 newtons, 6 to 8 kgs or 13 to 16 pounds. The maxillary occlusal forces on an average is 50 psi. For natural teeth, it is 150 to 250 psi. Then Boo's biometer measures the maximum forces of the jaw. And swallows per day is 600 times we swallow each day. PDL per arch is 45 centimeter square. Most common fracture is the fracture of a maxillary denture. Especially the fracture is present in the midline. So midline fracture 60% of the cases. Second most common is the mandibular denture fracture. And the most common reason being dropping of the denture, which is 53%, and poor retention of the denture, because the mandibular ridge resorb faster, so there is poor retention of the mandibular denture and poor fitting of the mandibular denture, which is more frequently, and that is the common reason for the fracture of the mandibular denture. This is a metal denture. So metal denture, the advantage is that because of this metallic part, there is thermal conductivity. So when a person is drinking hot, he feels something hot, so it feels real. So that is why it is a disadvantage. It is an advantage that the patient feels if he is eating hot or cold, because there is thermal conductivity through the metal and patient feels that. So, the patient doesn't feel everything artificial, something natural the patient feels. That is the advantage of metallic denture, that is there is thermal conductivity, also lack of bulk with more strength. This metallic denture is dimensionally stable. But the most important disadvantage is that it is difficult to reline. Acrylic is very easy to reline. So it is difficult to reline and adjust. So adjustment is very difficult also because of the metal incorporation. The cost is high and it has got more weight because of the metal. Acrylic is very light. So these are the advantages, disadvantages of the metal denture. So this is about the crash course for the complete denture. This is just to revise all the syllabus in a 1 day or in 2 hours of time. So basically we can cover the prostho CD we have covered now, and whole prostho you can revise it in a day. So you can just revise it in half day, 4 to 5 hours, and then again you can watch the video, increasing the speed again. So at least 1 to 2 times, up to 3 times you can revise one subject in a day, and that is the motto of our crash course, so that you can cover one subject in a day and you can master all the subjects in last month of your exam. So you can clear your NEET exam, you can master all the subjects just in a month, and that's the basis of our crash course. So guys, keep revising, keep reading. All the best for your exam.